Welcome to the podcast series, Rooted in Wellness, sponsored by the F.E. Berry Training Institute. The F.E. Berry Training Institute is funded wholly or in part by the government of the District of Columbia, DC Health, HIV/AIDS, hepatitis, STD, and TB Administration, or as we like to say, HOSTA. Rooted in Wellness is a podcast miniseries dedicated to exploring holistic approaches to health and well-being. Join us as we delve into topics such as trauma, HIV, mental wellness, and the social determinants of health, all with the goal of helping you cultivate a balanced and thriving life. Today's episode, Trauma at the Root of Health Outcome Disparities. It will delve into the profound impact that trauma has on health outcomes across diverse populations. So I'd like to introduce you to our speakers, Ms. Leisha McKinley-Beach, who is an author, a thought leader, inspirational strategist, trainer, and community organizer. Mrs. McKinley-Beach is the founder and CEO of the Black Public Health Academy. Then we also have Dr. Ashley Elliott, also affectionately known as Dr. Viiv, is a doctor of clinical psychology located in DC. She has a passion for serving those who identify as Black, Indigenous, persons of color, and members of the LGBTQIA+ communities. Welcome, ladies. I'm super excited to have you.
Thank you so much.
So let's jump into the conversation. Could you define medical mistrust, trauma, and health disparities?
Oh, yeah. I mean, talk about literally jumping in, Dr. Elliott. Well, why don't we start with medical mistrust? And just kind of a classic textbook definition would be suspicion of not just like clinicians, right, but suspicion of the entire healthcare infrastructure. And so whether that's hospitals or pharmacies, clinicians, like there may be something that doesn't feel right based on what we have heard, what has been told through storytelling, or what I have experienced personally. And so I don't know, Dr. Elliott, would you like to add to medical mistrust?
That actually was a perfect definition. You know, we gain mistrust by, like we said, experiencing things that are negative and have impacted us in a negative manner, or like we said, generationally or community-wise, familially, hearing stories of things that did not honor us as persons, made us feel like we were further traumatized or victimized, or we felt like we were not seen, heard, or respected. And that mistrust is valid in a lot of underserved communities.
Yes.
Absolutely. And both amazing definitions. And when we think about medical mistrust, it doesn't necessarily have had to happen to us specifically.
That's right.
Right? It could have happened to grandma, grandpa, a friend, an educator, a community leader. And all it has to do is be passed on, whether that's verbally, whether that's, visually. There are many, many ways that medical mistrust can kind of seep into our systems as a people, right? And that takes us to trauma, right? What's a good definition for trauma?
You want to go? Okay.
Go ahead, doctor.
So when we talk about trauma, it has a lot of things in common with medical mistrust, actually, because with trauma, there are incidents, again, that can adversely impact us, whether they're dangerous to person, danger to spirit, danger to thought, danger to community. And these things, of course, can be directly or indirectly experienced, or it could be due to generational experiences. Like we talk a lot about generational trauma within the Black community and how the experience of our family members and our ancestors have a great impact on our current mood state, our current function, and our ability to be seen as a functional individual within our society. So traumas can be due to a naturally occurring thing, let's say like a hurricane, a flood, a fire, or trauma can be due to being exposed to any type of abuse, any type of violence, or any situations where your rights as a person have been challenged by discrimination, stereotype, or any direct or indirect harm.
I couldn't have said it better myself. Absolutely. Mrs. Leisha, do you have anything to add?
No, well, two things. One, would be invite me when you have Dr. Elliott, because the way that she describes these experiences that we have faced and continue to face really honors our rich legacy and the ancestors. And I think that is so important as we talk about those things that impact our future and our present. They are a part of that legacy. And so whether this is an event that happened only once, or whether this is was a chronic experience that happened, again over and over again, as Dr. Elliott described, that we have to uplift and acknowledge the impact that it truly does have on us as individuals and then collectively as a Black community.
Yes.
Absolutely. Absolutely. And that impact, right? It could be things that we see, that we feel, or things that we're just naturally unaware of because it's so systematically, rooted within our cities, our towns, our governments. We may not even know, that it's
Right.
affecting us. And that takes me to health disparities. What's a good kind of like summation of like health disparities?
CDC has a definition around health disparities that I think is really going to center this conversation on today. And they talk about these are preventable circumstances, right? And I really want us to kind of center that these are preventable circumstances that may happen specifically to a racial or ethnic group or gender group, and in some instances, both groups, and that particular population is carrying far more than its share of the burden.
Absolutely. Absolutely. I would like to add, like, the word is preventable.
That's it.
That there could have been some type of action or some type of change or movement within a system to protect these groups that are underserved. And the socially disadvantaged populations, like Leisha has described, ethnic groups, gender, all of these things. The other part that I would like to add is that these preventable differences are usually purposeful. And that's something that we don't talk about enough, whether it be redlining, whether it be gentrification, whether it be removal of grocery stores or the shutting down of free resources or low cost resources for a population, for a community. All of these things are preventable. And all of these things are due to a systematic allowance of these things to occur within the population.
Oh, absolutely. And again, kind of like we were discussing with trauma, a lot of the current generations, don't see or feel that impact. It has been so normalized, that they don't see or feel that impact, but they are part of it at the same time. It's a very interesting kind of perspective to have working in public health and seeing how people are affected and them not knowing how affected they are compared to their counterparts, right? And so that kind of takes me to the discussion I would love to have about how experiencing trauma and health disparities impacts decision making when it comes to our personal health. How have you seen that in your work? It impact decision making?
Well,
I think that, oh no, go ahead, Dr. Elliott, go ahead.
I was lending the floor to you.
I was gonna say something that I think we all can contribute to, that we all have current experiences, either with ourselves or family members, loved ones, around the COVID pandemic.
Mm,
And there was more talk about the syphilis experiment in Tuskegee than probably in the past decades,
mm,
as a way of people uplifting their concerns and their fears, right? And what's so interesting about it was some of the information wasn't even correct, but they knew something happened to us
mm,
in Tuskegee, Alabama. And because of that, having a vaccine on the market so quickly caused caution and concern. If that's not a classic example of how trauma impact folks' decision, right,
mhm,
on whether to receive a preventative service or not, I don't know what is.
It's a classic example, and I love that. We see that with COVID vaccine. We've seen that with Mpox. We've seen that with anything related to getting care with HIV, AIDS, or STDs. Like there are certain people who will say, "Oh, I don't want to go to Whitman Walker because I don't want people to know," or they remember a time where you were outed because
mhm,
you went into a place. And then we talk about it deeply from a neurological and a psychological level. When you're repeatedly exposed to trauma or you're exposed to a severe enough trauma, your neuronal pathways operate differently. Your
mhm,
brain starts to rewire itself in order to protect itself from a trauma, from this happening again. So it may look like, yes, I'm not going to go to this clinic. I'm not going to go to this doctor. And then it may generalize to, I don't trust doctors. I don't trust any clinic. It may
mhm,
look like, hey, the last time I was over here, I was abused. I was harassed. I was bothered. I'm not going to go to that neighborhood to when it gets too populous during a certain season. I'm not going outside as much.
mhm,
So trauma really plays a huge role on how we protect ourselves, how we prepare ourselves, and how we think about the results and consequences of our behaviors and our actions. And if there are more cons than pros, we are more likely to lean into protecting ourselves by avoiding or escaping situations that we feel don't serve us.
mhm.
Mhm. And I
Absolutely.
would just like to add to that we start out talking about how the decision making based on traumatic experiences impacts the end user. So those who are seeking services. But I would also say that we have to look at how traumatic experiences also impacts those of us who provide
Absolutely.
services. Yeah, and for me, starting my career so young, I had the experience of seeing people die
Mm,
before there were antiretrovirals, right? And so what we did have, people who looked like me still didn't have access to it. But even with that little bit, we still were denied some of those medical advances. And so we stood at the bedside and you watched people die. And I didn't realize how much that had affected me. And I had not dealt with it until COVID came on the scene. And so here we go again with individuals that look like me, not having access to the same screening, the same medication, not being able to be at home because we're frontline workers. And all of those feelings of helplessness then resurface from what I saw 20 years ago. And so I also want us to acknowledge and uplift the trauma that those of us who provide service go through and how it impacts our decision making as well.
Yeah, I would love to tag in on for that because I've been through a lot as a millennial, processing events around us. And as a clinician, a conversation I've had with my fellow clinicians, especially clinicians of color, and during the latter half of the 2000s, especially in the last 5 years, we talk about Trayvon Martin, we talk about George Floyd, we talk about Sandra Bland, we talk about us constantly having to deal with some type of violence or trauma and loss and processing it with our community. We talked about the COVID-19 saw so many healthcare workers and clinicians like myself very burnt out. Never had I had so many referrals before. And in the impact and decision making, we saw people leaving the field. I can't
Yes.
do this anymore. So that means that we have less resources for people who look like us because people find comfort in healthcare workers who share like experiences. So you had that. You had some people changing what populations they were working with. So when we're talking about palliative care, we talk about people with cancer or later stage AIDS that have complications with other health issues. I can't work with this. I can't because it's so much. And I'm tired, like you said, I get tired of seeing death. I get tired of, trauma. When you see kids being taken from their homes and you can't intervene, but you're supposed to be a healer in this
Right.
intervention, those things affect our decisions for how long we're going to do this, if we have the capacity to do this, if we want to move into another realm of industry, or if we want to retire. And because also when the system doesn't back you,
That's right.
traumatizing. And that leads us to make decisions for self versus other. And that's not necessarily a bad thing, but it definitely impacts care.
Absolutely. And it's something that I think a lot of people on the outside don't consider when they're reporting to, our clinics, our hospitals, that the burnout is real, specifically for people who are serving the communities that they're from, that they look like. Because we do tend to gravitate towards those clinicians, towards those doctors, nurses, because we want to feel some bit of comfort, even though there's a mistrust, I'm more prone to trust someone that looks like me, that understands my experience, right? And that can burn them out, right? That can, some of these city clinics, that are day in, day out, with a lot of the problems that Black and Brown communities are facing, they are burnt out, they are tired. And it's kind of one big circle, right?
Yeah.
Someone's reporting to a clinic, they're not getting necessarily treated the way that they feel like they should be treated by a Black or brown doctor. That then creates mistrust, that then creates trauma, that then gets passed down to their kids, their aunt, their uncle, their whoever in their family. And it just keeps goes and goes and goes. What do you think we can kind of do to prevent that? What do you think we can do to educate those on the outside about, medical mistrust, and educate those on the inside about, lessening burnout so that people are having good experiences when they report to their clinics, their hospitals?
Mm. That's a good question.
Yeah. In a very complex question. I think that if we look on the inside, and this is actually one of the reasons why I started the Black Public Health Academy, and this spoke specifically to health departments, because there are some experiences, some qualities that health departments have for people who come from communities that have been disproportionately impacted by HIV, that are not valued, they are not compensated, but truly are utilized to benefit the infrastructure, the system, right? And so helping folks to advance to the decision-making level from those communities has become my personal mission. Why? Because when you have lived through those experiences, you understand why Leisha comes in the health department and you're asking her about questions about her sexual health, about intimate relationships, and she is reluctant to respond to you. Why? She is operating in one of our cultural norms. Like that type of information about what has happened in this house, what stays in this house, right? And so I need to be connected or engaged with a Dr. Elliott who says, look, I understand it. I know where you're coming from. That's a level setting, right? That's a power shift. That's cultural humility to say, look, I'm not going to tell you that my way is the best way. What I am going to tell you is that I am meeting you where you are, and where you are may come from that cultural belief that you can't disclose what's happening to you sexually, but you have made the first step to come into this place. Right. And when I feel that, when I feel like you understand without me having to even tell the story first, that builds the bridge with trust. We have so many of our lower level staff, like disease intervention specialists. You can pick an urban city, and I promise you that when I look at the percentage of staff that fill that position, it is overwhelmingly Black. When you look at the people who are the decision makers, those that can determine the culture of the health department or the organization, it becomes lighter and lighter. Right? And so if Leisha has just had an experience that lets her know this is the right place because of her encounter with Ashley. We ain't even got to Dr. Elliott, just Ashley. Then why wouldn't we be grooming Ashley to become the director of case management, the surgeon general for this region? Those positions are important, and the leadership sets the stage for the culture as well. And so I do think that that is extremely important in how people come in to receive service, how we bridge that gap around medical mistrust, how we own the implicit bias that comes when you don't understand our story, you don't have the lived experience, you make some judgments, right? Some biases about what I need and how I should receive it.
Absolutely. Come on. Yes. I just feel so strongly about both parts of the question. So when we're talking to clients, because I do client-facing work, I'm very aware of how re-traumatizing, retelling, and reliving your story can be. So as a clinician that now trains clinicians and helps train other professionals in the healthcare industry, I always say we meeting with people where we are. Like Leisha said, I'm meeting you as Ashley. My title, it was bestowed upon me because of my work, but my mama named me Ashley. I'm gonna meet you the way my mama would tell me to see you as a human. And when I'm getting to parts of intake or parts of therapy sessions where I have to ask some hard questions, I always preface it with, I understand this may be difficult for you. You may be tired of repeating yourself, or it may take you to a place. So if you're ready, we can do that. If you would like me to ask some other things related to your history, I can. I will tell you that having this information will lead to me better being able to interpret information for you and figure out the best role for treatment. But I want you to be comfortable. And that's a human piece. I'm connecting with you on a human level. Yes, I want you to give me this information. I'm telling you why, too, because sometimes we deal with communities where information is being gathered by health agencies or wellness services, and they don't know what happens to it. They're like, what happened to that survey or information, that data that you did 6 months ago, 2 years ago? So I'm telling you, I'm using this information for your treatment. I'm also letting people know that by HIPAA, I am bound to keep your information confidential and assert privilege, which means I will protect your information to the death of me. And then we talk about the clinical piece, literally something I am doing. I want to make sure that clinicians, that therapists, the psychologists understand what they're getting into. And just because you come from a community, like Black people or brown people are not monolithic. So you may have a different lived experience than these clients that you are seeing, and how to check those biases and those assumptions and those stereotypes and those prejudices, but also understanding how you going to take care of yourself while you're exposing yourself to the ills and the traumas of this population. And that's my part, to try to help the system from in. And then as you're doing it, exactly as Leisha said, if you see a clinician, if you see a practitioner, if you see someone that is able to have such a great rapport, such a great track record, and they're really knowledgeable and they're willing to do more to expand their knowledge, that's when they become a clinical supervisor, a clinical director. That's when you put them in the field and you DBH, they're the talking head. That's when you're getting people to help change the curriculum for how we're dealing with social work and how we're dealing with therapy, how we're dealing with other change agents in the community. Because if we continue to bring people into the system with high expectations, with no work done, we won't get anywhere. It will just continue to be this aspirational goal. So thank you, Leisha, for bringing all of those things up.
Oh, no, thank you for bringing it home. Very well said, and really lays out what the foundational problem is, right? We can't get to solutions to many of these issues until we own what got us here in the first place. And Dr. Elliott just really laid that foundation.
I love it. I love it. And I appreciate both of you bringing your experience, not only as, public health officials in your fields, leaders in your fields, but also as Black women, because it's a different experience, as we have discussed today. And as you said, Dr. Elliott, we are not a monolith. And so those experiences are going to be very different, very nuanced. Everyone has their own challenges. And so just thank you so much for bringing that to us today. I'm going to close this out and ask one more question for both of you. If you could, what would be the first thing that you would tackle within your power, obviously, as far as trauma goes within the Black community? What would be one of the first things you would try to tackle?
I think for myself is the validation of trauma. Because so often in our community, we are told, get over it. That was the past. I'm not like that. We're trying to help you now. It's very combative because people are offended by the fact that people won't just, take them in and receive information or services with open arms. We have to validate people's experiences. And though it may have happened 20 years ago, it's still relevant right now. Though it may have happened in the 60s, it may have happened in the 40s and the 50s, it may have happened in 1819, is still relevant now. And when we talk about those generational traumas or those individually specific traumas, the first step to breaking through any communication barrier is the validation of an experience that shows respect. And respect helps build rapport. And rapport helps create change. And change helps people be more receptive to treatment, more receptive to resources. So I think that of course the clinician would be like, let's validate. But that's how we get there. If I don't respect you as a person or you don't respect me as a person, we're not going to collaborate. We're just going to challenge. And validation of experience. And the thought it's not all in your head. It's not made up. Oh, that's not just a story. That's not pulling a race car. All of these things need to be addressed so that we can respect each other to work with each other instead of feeling like you work for me or you aren't going to be receptive. So let me just do my bare minimum.
I would say part one for me is for those of you who are watching this, that's the blueprint. Dr. Elliott just laid out the blueprint. So my part is very small, and quite personal. That for me, in addressing the trauma, I would eliminate a word from our vocabulary, and that is resilience. Why is it, right, that we gotta honor and uplift and celebrate that I was still able to overcome, or I was still able to receive the health outcomes I desired in spite of? It should always be a level playing field, but there's something about celebrating that we know that it won't be a level playing field. We know that you're not going to be treated the same. We know that you're not going to be afforded the same dignity and respect that Dr. Elliott referenced. But in spite of all of that, you still came in, or you still came back. You still worked the health plan. So, no, it shouldn't be in spite of. It should be that because of my human experience, I am afforded the same level of respect, the same level of care, the same level of service, the same level of attention as everyone else. So yeah, so I would eliminate resilience. We shouldn't have to, in this day and time, we shouldn't have to be uplifting and celebrating that all of those obstacles I overcame to get the same thing that other people did.
Absolutely. I love it. I love it so much. Both your answers just warms my heart to know that there are people out there doing the good work, such as yourselves. Thank you again so much for lending us your voice, your talents, and your expertise in your respective fields. And then thank you to everyone for tuning into this episode. We hope you found this conversation engaging and informative. Stay tuned for more insightful discussions in the future. And remember to subscribe, rate, and review. And this will help us reach more listeners. Until next time, thank you, everyone.